Hi everybody, it's Dr. Barone. I heard you guys are having an exam today, so I'm sending good vibes your way, sending good vibes to Indy. Hope you guys do really well on it. But I scheduled the time, so I'm going to just record this tape for you so that way you can have something to watch when you come back. But I tell you, it's lonely without you. See, that's how you know you're really missed. I miss you guys. All right, now let's get right to it. CNS, this is our final chapter, and man, it is an important one. We've got lots of micro-integration, we have lots of anatomy integration, so very testable. Now some basic foundations. What does the brain do when it's injured? How does it react? Well, let's start with the neurons, right? The brain is made up of neurons. That is the signaling pathway, that's how we think. You lose neurons, you lose thoughts, you lose your ability to create thoughts. So reactions of neurons are very important. Now, unfortunately, neurons are very susceptible to hypoxia. So if there's acute injury, especially hypoxic injury, neurons will get injured, they'll shrink, and they'll die. How long does it take for neurons to start dying? 5 minutes without oxygen. I'd say 5 minutes without oxygen, neurons start dying. They're one of the most sensitive tissues in the human body. So when they start dying, well, it takes some time to see it, but usually by 12 to 24 hours after an irreversible hypoxic ischemic insult, the cells will start shrinking and they'll get very, very eosinophilic, very pink. So we call them red neurons. That is the morphologic appearance of cells that have died. So again, they die within 5 to 10 minutes, they start dying. But to see their death, it usually takes time. It takes several hours to see them. Once they're dead, they're gone forever. The ability of the brain to regenerate is very, very low. So we call these red neurons. They're shrunken. See the way this cell is shrunken? It's very red, and the nucleus is very dark, very pyknotic. So this is a red neuron. Now, I always remember, Superman dies under a red sun. Neurons die as red neurons. Yeah, this is what happens when neurons undergo necrosis or apoptosis. They shrink, they darken, and well, here's the features right here. Shrinkage of the cell body, very dark nucleus, we call that pycnosis. That's an irreversible change. Once you get pycnosis, that cell's never coming back. The cytoplasm is very eosinophilic, very, very pink. You see disappearance of the nucleolus because the cell is no longer proliferating, it's now dead. And loss of the missile substance. Remember, that was that basophilic material that represents the RER and the Golgi. So it's the synthesis apparatus. It's mostly RER and ribosomes, really. That's what the missile substance is, RER and ribosomes. Right, now what if the injury is slower? Well, if it's subacute or a chronic injury, well, then the cells kind of degenerate and they undergo apoptosis and die. So a lot of degenerative brain diseases are usually accumulations of abnormal proteins. They accumulate and accumulate, and then you get the unfolded protein response, where the cell tries to ubiquitize and destroy it, but gets clogged up, and the cell undergoes apoptosis. So a lot of the degenerative brain diseases, we're going to see loss of neurons due to apoptosis. And again, this is a slow death, slow evolving. So diseases like Lou Gehrig's disease or Alzheimer's, where neurons are slowly lost over time. Now, for morphology, what we'll see loss of neurons, and that's going to produce dementia. So the more neurons we get, the more neurologic deficits we'll get. And of course, it depends on which neurons are lost. That will give you the symptoms. Now, sometimes it's hard to notice. It's hard to notice initially when you start losing cells. So something you always want to focus on the brain is what's called scarring. In the brain, you don't get good scars. You get what's called gliosis, proliferation of astrocytes. So astrogliosis is actually a better term for it, but we just call it gliosis for short. So that's the way the brain scars. So when it gets injured, neurons die, and then astrocytes proliferate. We call this gliosis. So look for the term gliosis. When you see that, that means the brain's been injured. And you'll start to notice the neurons are missing. Okay, so that's a chronic degenerative loss of cells. All right, now what happens if the axon gets cut? So it's not a problem with the cell body itself, but the axon gets cut. Well, you can get what's called an axonal reaction. And this is best seen in the anterior horn cells of the spinal cord when the motor neurons are cut or damaged. So if I cut the motor neurons, maybe a traumatic cord injury, if I cut them, Well, what will the cell body do? Well, let's see. Here's the cell body sitting in the anterior horn. And then, of course, it's got an axonal process that goes way down the spinal cord, way down. Well, if it gets cut, it gets transected. Distal to that, you'll get Wallerian degeneration, right? It'll start to degenerate. But up until this point, this cell body will try to regenerate. So it's going to try. So what will the nucleus do? It'll try to synthesize more stuff. So now you'll start to see enlargement and rounding up of the cell body because it's trying to synthesize more things to try to get the axon to grow back. You'll see peripheral dysplasia of the nucleus is kind of pushed over, and you'll see a prominent nucleolus because this cell is now trying to synthesize like crazy. And you'll see a lot of peripheral dispersion of the Nissl substance. So all the Nissl substance moves over here because you want to synthesize lots of proteins. So that protein synthesis from the cell body, well, now all that protein will come down here, and then you'll start getting a swelling here, a bulbous swelling, and you'll start getting sprouts, axonal sprouts coming out, trying to reconnect. Oh, it's so cool. See, your neurons want to regenerate. They want to connect. The problem usually is you get scarring here. When you get scarring, then the fibers can't find each other. The two ripped pieces can't find each other. So you get these little sprouts, but it can't find it because of fibrosis. So that's one of the things we're trying to do. Whenever there's a cord injury, we're trying to decrease inflammation, prevent that gliosis, which is the scarring of the brain. Because the gliosis is what seems to interfere. If we can lay down like a track, like a signal, that allows one part of the axon to find the other part, it would probably reconnect. It would make a new connection. That would be awesome. So that's what we're trying to do. Stop the inflammation, stop the scarring to allow some of the cells to reconnect themselves from this little spouting. So again, the cell body is trying to increase protein synthesis and then send out axonal spouting, trying to regenerate the axon. Now, if we take a look at this picture, here's one of the cell bodies. I don't see the nucleus in this particular plane. Here's another one. Notice these are for pretty big cell bodies. Notice the nucleus in this one is pretty big and it's got a prominent nucleolus because the cell is synthesizing. Now, at the other end is the axonal where it got cut. Well, that's going to start swelling up. You're going to get these swelling areas here. This is the end where the axon actually got cut. And all these, by the way, are astrocytes. This is the astrogliosis. These cells are proliferating, making this little, it's a very ill-defined scar. Brain doesn't scar very well. Now, what do we call these dilated ends, these bulbous projections here? At the end where it's trying to sprout, these are called axonal spheroids. Spheroids. And these are just bulbous swelling at the sites of disruption because all the proteins are coming down there. They're all coming down to the end, and it's like the railroad track ends. So all this stuff accumulates there. And then hopefully that will start making sprouts, and hopefully it will reconnect. All right, now in the brain, we also have accumulations that can occur. So when we have damage to the brain, you can get alterations of a subcellular level, and you can get accumulations like inclusions. So we're going to have cellular changes at a subcellular level, and we're going to see inclusions as well. And those are always testable. If there's an inclusion in the brain, they're going to ask you, what is it and what's it made of? So that's always important. Now, one inclusion you'll see in neurons of older people, it's a sign of aging, a sign of wear and tear, is lipofusion. Lipo is lipid, and fusion is kind of brown. So it's a yellow-brown pigment. You'll find inside the cytoplasm, and it's accumulation of complex lipids that have been peroxidized. Free radicals damage them and cross-link them. It's like cross-link membrane. Now, they're in lysosomes in the cytoplasm. The lysosome's trying to break it down. They can't. It's just indigestible. So over time, it's going to accumulate, and you'll see it as a sign of aging. So I don't have it, you don't have it, but when we get into our 70s and 80s, we may start seeing some lipofuscin in our brain. And if it becomes very severe, your brain can actually start turning yellow. They call it the yellow-brown atrophy of the brain and other organs, the heart, the brain. They start atrophying over time from wear and tear. Now, another inclusion is viral inclusions. Yeah, when viruses proliferate, their proteins will accumulate. Now, the rule is if it's a DNA virus, it usually has intranuclear inclusions because that's where they proliferate. So herpes simplex, you're going to see these Cowdrey inclusion bodies, and they're usually intranuclear. It's DNA. Now, for RNA viruses like rabies, we'll see cytoplasmic. These are called Negri bodies. These are viral cytoplasmic inclusions. Now, there's a couple of exceptions to the rule. Like one of them would be CMV. CMV is a DNA virus, so we would expect to see intranuclear inclusions, but we're also going to see cytoplasmic inclusions too. CMV kind of plays the field. It plays both areas. So that's kind of an exception. Most of the time, DNA is nuclear only. This is nuclear and cytoplasmic. All right, so that's viral proteins accumulating. What about abnormally misfolded or ubiquitinated fibers that are not being broken down? Well, that's going to occur in neurodegenerative diseases like Alzheimer's and Parkinson's. Yes, for Alzheimer's, we're going to have accumulation of amyloid, but we're also going to have accumulation of hyperphosphorylated tau protein. Yeah, tau is important for making microtubule assembly. Well, unfortunately, it's hyperphosphorylated, and therefore you don't assemble microtubules properly, and your neurons get injured. Well, anyway, you're going to see these tangles, these accumulations of hyperphosphorylated tau. It makes tangles. We call it neurofibrillary tangles. So always remember, tangles are made of tau. Tau tangles, tau protein. So another name for this is a proteinopathy or tauopathy, because this hyperphosphorylated tau is going to accumulate and then eventually lead to damage of the neurons. Same thing happens in Parkinson's. In Parkinson's, you also have accumulation. These are going to be called Lewy bodies. Now, these are made of alpha-synuclein protein. Alpha-synuclein. So it's a different protein. And here's the rule. In the brain, if there's some sort of body or inclusion, they're going to ask you what it is. What is it made of? So neurofibrillary tangles are made of tau. Lewy bodies are made of alpha-synuclein. Now, what about a prion disease, which is an infectious protein? Well, Creutzfeldt-Jakob, CJD. This is a very rare disease, but man, is it sexy. This is a transmissible infectious protein. Whoa, never before. We had viruses, bacteria, fungus. Then we came up with a new category of infectious proteins. It's a protein that can infect you and basically convert your normal proteins into abnormal proteins. Really weird group of diseases. So these are very rare, but Board likes to test things like this. Now, these are diseases that are called the spongiform encephalopathies. Why they call it spongiform? Because your brain looks like a sponge after a while. Yeah, the gray matter develops vacuolation of the neuropil. So you're going to see extensive vacuolation of the perikaryon, that's the cell body of the neurons, and also the neuronal cell processes also get vacuolated too. So you get a bunch of vacuolations in your neurons. Well, now you have a holy brain, looks like a sponge. No wonder you get dementia. Your brain is full of holes. So that's not such a good thing. And that's due to this prion protein accumulation called spongiform encephalopathy, spongiform change. All right, so very testable. They like these inclusions a lot. All right, now what about astrocytes? How do they react when they're injured? Well, when there's brain injury, these are the guys who act like fibroblasts and try to make us a rudimentary scarring. And the brain, you don't get very good scarring. Now, we all know astrocytes, they call them that because they're star-shaped. They look like a star. So look at this, the astrology, right? So astrocyte, if we take a look, they really do look like stars. Like stars in the night sky, stars of your brain. Now, they contain glial fibrillary acidic protein. This is a good marker for them, GFAP. But of course, it's not specific. Any supportive cell of the neurons, they're called glial cells, right? So we have oligodendrocytes, which myelinate them. We have ependymal cells, which line ventricles. Those are also going to be glial, and they're going to be GFAP positive as well. So this is just a nice stain, a nice marker to tell me it's a glial cell and not a neuron. Now, what do the astrocytes do? Well, they work as metabolic buffers. They also detoxify stuff within the brain. They can eat stuff and detoxify. And they also contribute to the blood-brain barrier. If I was writing a question, this is what I'm going to ask about. Blood-brain barrier. What creates that wonderful barrier? Well, around the blood vessels, the astrocytes wrap their processes, and that creates a barrier. It doesn't let chemo in. So very important. Your brain is a very privileged site. Only certain things get in. So blood-brain barrier, part of it is produced by the astrocyte processes wrapping around blood vessels. All right, now when astrocytes see injury, they start to proliferate and they create scarring. They can lay down a little rudimentary fibrosis. This is called gliosis, or better, astrogliosis. So I can remember it's the astrocyte that's causing the scar. Now, this is one of the most important indicators of CNS injury, because as I mentioned, it's hard to know if there's less neurons than normal. I mean, you can start counting how many per field, but it's kind of hard to like ballpark it, unless it's very severe. When you have a lot of neurons lost, you'll notice that. But initially, it can be very difficult. So this is an important marker of CNS injury. Whenever I hear gliosis in the brain, I know that brain has been injured in that area. Now, gliosis occurs when there's hypertrophy and hyperplasia of the astrocytes. They start proliferating, so it's in increased numbers. In fact, they become very large. When they do, we give them a fancy name. We call them gamistocytic astrocytes. It's just an enlarged, very active, plump astrocyte. Yeah, it's got a very enlarged vesicular nucleon. It's got prominent nucleoli because now it's getting active. It's going to start making some little bit of collagen. And it's got abundant pink cytoplasm. So that's really the key. They start becoming big and plump and pink cytoplasm. That's an active astrocyte. That's an astrocyte that's no longer just sitting there. It's actually getting activated and doing something. Now, this is kind of a confusing one. Alzheimer type 2 astrocytes. So I was like, that's for Alzheimer's, right? You're like, well, not exactly. We found it in an Alzheimer's patient, but it wasn't because of the Alzheimer's. Could you get any more confusing? So what was it caused? It was in an Alzheimer's patient, but what was it caused by? Well, these are astrocytes that have very large nuclei, prominent nucleoli, so again, they're very active, but they have an intranuclear droplet of glycogen. They got this little droplet inside the nucleus. Now, we see this when there's high levels of ammonia, okay? So that's going to be a problem with your liver detoxifying. So we're going to see this with chronic liver disease patients, like cirrhosis patients, like patients with Wilson's, and of course, disorders of the urea cycle. If you have trouble with urea cycle, you get hyperammonium, you're going to see these Alzheimer's type 2 astrocytes. So again, it's kind of a confusing term. It's got nothing to do with Alzheimer's. We just found it in Alzheimer's patients, so they called it that. But this is more to do with high levels of ammonia, because these are metabolic. They try to detoxify, they try to buffer for us. So when there's high level of ammonia, they try to protect the brain a little bit. That's interesting, huh? All right, now what about some inclusions in the astrocytes this time? We talked about neuronal inclusions. What about astrocytes? Well, a famous one is called a Rosenthal fiber. You'll see this whenever there's chronic gliosis, so chronic active astrocytes, you're going to see this accumulation, these Rosenthal fibers. Now they're pink, they're in the cytoplasm, and they're accumulation of heat shock proteins, GFAP, and ubiquitin. Just accumulation of this stuff. You try to ubiquitinize it, you try to get rid of it, it just seems to accumulate. Now, when you see the term astrogliosis, or I should say Rosenthal fibers, you want to think about long-standing astrogliosis. That's when you see it, when astrocytes have been active for a long period of time. But for USMLE purposes, I want you to remember Rosenthal fibers with a tumor, pilocytic astrocytoma. This is the most common brain tumor in children. So very important to remember pilocytic astrocytoma. It's a grade 1, which means it's a low-grade tumor, which is a good thing. So we usually cure it. It's usually curative. Now, what does pilocytic mean? Well, cytic is cell, right? Cell body. Pilo means hair. So these astrocytes get really long. So here's their nucleus. But notice they have these long bipolar processes. So they look long like a hair. Sounds like they got the name pilocytic because the astrocytes are really long like hair. Now, in their cytoplasm, they tend to accumulate all these heat shock proteins, GFAP, and you'll see these pink, like a corkscrew. They look like a corkscrew. They look like corkscrew inclusions in the cytoplasm. These are called Rosenthal fibers. Now, again, they happen anytime there's turned on astrocytes. But I want to remember with pilocytic astrocytoma. It's one of the key features I'm going to think of. So you say Rosenthal fibers, I say pilocytic astrocytoma. Now again, you can also see Rosenthal fibers with another disease called Alexander's disease. This is one of the leukodystrophies. And what it has is, it has a mutation in GFAP, the gene. So if you have a mutation in this, it's going to be misfolded, it's going to accumulate, and it's going to make Rosenthal fibers. So again, this is a genetic disease. We have leukodystrophy, white matter tends to break down. because of GFAP accumulation. Clogs up the cells start to die, and of course you'll also see Rosenthal fibers here quite a bit. So Rosenthal fibers, remember polycytic astrocytoma. Now another inclusion that you'll see with astrocytes is corpora amylacia. Corpora amylacia. This is seen in older people. So we see with advanced age, and it's probably a degenerative change of astrocytes. Now it's made mostly of this abnormal form of glycogen. It's called polyglucosan. Polyglucosan. So it's an abnormal form of glycogen that seems to accumulate. It makes these layers. It's PAS positive. PAS positive because it's a form of glycogen. It's an abnormal form of glycogen. Now, corpora amylacia, kind of low yield. It's just a degenerative finding in the brain of older people. But one thing that's important is a Lafora body, which is very similar. It's like the same stuff, same exact stuff, but it's seen in a disease. So Lafora body is seen in a disease called Lafora disease. No way. Wait. Lafora bodies are seen in Lafora's disease. Now, Lafora's disease is a form of monoclonal, or essentially myoclonal epilepsy. So Lafora's myoclonal epilepsy. So it's an epilepsy disorder. And again, it's due to the abnormal form or accumulation of glycogen, which is the polyglucosan. Now, this has been asked on the exam. They said a patient comes in and they have epilepsy. On autopsy, there are Lafora bodies. What is a Lafora body made of? See, I told you, whenever there's a body in the brain, they're going to ask you, what is it? So it's made of this abnormal form of glycogen called polyglucosan. So that's what I want you to remember. And again, if it accumulates as you get older, you just call it corpora amylacia. But in this disease, it accumulates like crazy in the cytoplasm of neurons. Okay, so they're called Lafora bodies. All right, now we got one more cell we should talk about, and that's the microglial cell. This is the macrophage of the brain. It's the macrophage of the brain. So these come from mesoderm, they come from monocytes, they circulate around, and then they find their way to the brain. Now their function is to stay in the brain and eat stuff. So they're called fixed, or they're residents, they're living there, fixed macrophages of the CNS. Okay, so fixed is the fixed macrophage system of the CNS. Now, they have the same markers as all other macrophages. So monocytes, macrophages, they're all CD68 positive, and so are these cells. They're just macrophages of the brain. Now, when there's an injury, they're going to proliferate because they're going to eat the dying and dead cells. They're going to develop elongated nuclei. They become like rods. So the nuclei get long like rods. They call them rod cells. They're just a macrophage with a long nuclei. But they tend to form collections around areas of injury. We give a fancy name. We call it microglial nodules. Just a collection of macrophages. That's it, aggregates. And just going to eat some dead tissue. Now, if they're eating neurons, that's not a good thing. We call that neuronophagia. So they're going to eat stuff, and if they're eating neurons, that's not good because when your neurons die, you start getting dementia. So that's not a good thing. And of course, when they eat myelin, they're going to accumulate a lot of neutral fat from all that myelin, and they're going to call them Gitter cells, and they're full of all this myelin. So they eat neurons, you call it neuronophagia. They eat myelin from myelin disorders, myelin breakdown, we call them Gitter cells. It's a fancy name for a fat macrophage full of lipid. All right, now that was basically the general response to injury. That's what this brain does when it gets injured. Now let's talk about some specific types of injury. Now the first one we've covered already, edema, Starling's forces, right? We've covered edema already. In the brain, very important, because if I smash my finger with a hammer, well, it can swell up to 20 times the normal size, and I will never die. But my brain swells even a little bit. Remember, it's fixed. There's a skull here. It can't swell. So if the brain swells, it's going to hit the skull, and then it's going to get squished, and it's going to herniate, and you're going to die. So we don't want swelling of the brain. So remember, whenever there's an injury to the brain or spinal cord, starting some sort of prednisone, or I should say corticosteroids like dexamethasone usually, or betamethasone, something to stop inflammation is very important when there's injury to the brain or spinal cord. Now, by definition, edema is excessive fluid accumulating within the brain parenchyma. Now, what happens to the brain when it swells? The gyri get squished, they get flattened against the skull. The sulci, they also get squished, they get very narrow. Those are the spaces between the gyri. And of course, the ventricles will get crushed too. The brain swells, you crush the ventricular cavities, they get compressed. So everything's getting squished, and eventually the brain will herniate. So this is a cause of increased intracranial pressure. And I always like to work with differentials because the bigger your differential, the bigger the doctor. Right, gentlemen? Big differential. Carry a very big differential, and all the people will be impressed by you. So what's the differential of increase in pressure, intracranial pressure? Well, generalized edema. Generalized edema makes the brain swell. Number two, too much fluid in the ventricles. That's called hydrocephalus. Hydrocephalus. We'll see that coming up on the next slide. Hydrocephalus. Hydro means water, cephalus, brain. Too much water in the brain. And then finally, any kind of local expanding mass. Expansile mass. So a good example would be a tumor. How about a blood clot? How about a bleed? A bleed. How about a granuloma? Anything that's an expansile mass will cause the pressure to go up. So very important to know your differential. So again, there's a million things that increase pressure. These are the three big: edema, hydrocephalus, too much fluid in the ventricles, and then of course any sort of mass lesion gets bigger and bigger. Now, signs of increased intracranial pressure, well, headache. Very common to get a headache when your brain gets squished. So you're going to get a headache, you're going to get nausea and vomiting. Projectile vomit, like The Exorcist, is very, very frequent finding. And of course, if I look in your eyes, I will see papilledema. Never a good finding. That means your brain has high pressure. So look for that papilledema. And of course, herniation will occur. And we're going to talk about herniation too. That's coming up as well. All right, now what causes cerebral edema? Well, there's two major causes here. We have vasogenic edema due to blood vessels, and then we have cytotoxic edema where the cells get injured and the cells swell. So two forms: blood vessels get leaky and cells get injured and swell up. Now the most common is vasogenic edema. This occurs whenever the blood-brain barrier gets disrupted. It could be due to a tumor, due to inflammation from an abscess, meningitis, hemorrhage, whatever makes the blood-brain barrier leaky. Now fluid will shift from the intravascular blood vessel to the interstitial or intercellular space. So that's edema, too much fluid in the interstitium, in between the cells. That will cause the brain to swell. Now remember, interstitial fluid is usually drained by lymphatics, and there's not many lymphatics in your brain. So if you accumulate rapidly fluid in the interstitium, it ain't going away very quickly, because there's not many lymphatics to reabsorb it and get rid of excessive extracellular fluid. So not a good thing their brain edema. In fact, sometimes we use mannitol to try to suck some of that water back out of the brain. All right, now what about cytotoxic edema? Well, this is intracellular. So this is when cells get injured by some sort of toxin, then they swell. So it's secondary to either neuronal or glial or endothelial membrane injury. When you damage the membrane, the barrier between inside the cell and outside the cell is damaged, so now fluid can come in. This is going to occur whenever there's hypoxia or ischemia, because remember the membrane pumps are ATPases. If there's no oxygen, there's ischemia, lack of blood flow to your brain, no oxygen, no ATP. Now the sodium potassium pump shut down. Sodium leaks in, follows by water, your brain will swell. Now this also can occur if there's some sort of metabolic damage, like some sort of toxin to the brain. That can also injure the cell, and the cell swells because it's injured. So anything that damages the brain, ischemic injury is going to be a big one. Okay, now we're going to switch gears slightly here and talk about hydro means water, in this case CSF, in the brain, specifically in the ventricles. That's what I mean by in the brain, in the ventricles. So too much CSF in the ventricles. So when you have more volume of CSF, the ventricles are going to get bigger. They're going to expand. So look at the size of these. Look at these ventricles. They're huge. Wow. Huge, big spaces. Now, obviously, as this gets bigger, it squishes the brain against the skull. It just pushes. This pressure is going to push the brain and squish it. So that's not such a good thing to have. So this increased fluid can eventually lead to increased intracranial pressure, which will squish the brain. Now we have different forms of hydrocephalus, and this is sometimes confusing to students. I think it's pretty straightforward if you understand it though. So let's start with the most tested. They love non-communicating. What does that mean? It means the CSF can't flow from where it's made to where it's absorbed. Remember, it's made by the choroid plexus, then it goes through all the ventricular system, and then it gets absorbed right here in the midline by the arachnoid granulations. That absorbs it. So non-communicating means there's a blockage somewhere along the pathway, obstruction to flow of CSF. Now guess what? Wherever that obstruction is, proximal to that will dilate. So wherever you see the dilation, that can be a really good clue to tell you where the obstruction is. So when you do your CT, and you see, oh, the third ventricle is dilated, but the fourth one isn't. Well, if the third ventricle is dilated, but the fourth ventricle is normal, it's going to be the aqueduct of ciliatus that's blocked. And that's one of the most common types of congenital stenosis of the aqueduct of cilia. It's one of the most common causes of congenital hydrocephalus for a baby to be born with it. Now, obviously, as when we get older, tumors pushing on things and masses, bleeds, anything that pushes can cause obstruction as well. Okay, but as a kid, remember congenital stenosis. And that's the aqueduct of cilia, which is going to connect the third ventricle down to the fourth ventricle. Very good. All right, now what about communicating? Communicating means there's no obstruction. So why is there too much fluid? Well, either you didn't absorb it properly, so there's a problem with the granulations, and that's very common. Because if you get meningitis, it's going to scar the meninges, and those granulations get obstructed. So that's a very common cause of meningitis. Now, it can also be due to overproduction. Maybe you're reabsorbing it fine, you're just making too much fluid, so then it accumulates. Now, this is kind of rare, but it can be due to tumors of the choroid plexus. So again, communicating means the fluid can get from one end to the other end, there's no blockage, but either it's not getting absorbed properly, most common, or it's being overproduced. Now, oh, by the way, where will the ventricles be dilated? Everywhere. Everywhere. They'll all be dilated. Everything, because there's either not enough reabsorption or there's too much production, so everything has too much fluid. Now, here are two fancy ones. Hydrocephalus ex vacuo. Now, this is the term we're going to use when there's atrophy of the brain. So if the brain atrophies, there's less brain, well, now the ventricles have to get bigger just because there's no brain. So they just naturally get bigger. So this is the term we use whenever the ventricles enlarge because of the loss of brain parenchyma, either due just to aging, but usually they ask this with Alzheimer's, because in Alzheimer's, the brain significantly atrophies. Pick's disease, you'll get frontal temporal dementia with atrophy as well. Huntington's, anytime where there's severe atrophy of the brain, the term will be hydrocephalus ex vacuo. Now, what's the pressure here? Pressure is normal. Pressure is normal. Okay, so it's just too much fluid, but it's not because of pressure. See, this has increased pressure, this has increased pressure, squishes the brain. This one doesn't. So the CT shows you big ventricles, but it's just not squishing the brain. It's just big because there's not enough brain, that's all. Now, how about this one? Normal pressure hydrocephalus. Well, this means that most of the time the pressure is normal, but from time to time it goes up. So it goes up transiently, and then it goes back down to normal. It goes up, squishes the brain, then it goes back down to normal. So normal pressure hydrocephalus means if we measure the pressure, it's often normal, but there are episodes where it goes up and squishes the brain. Now this is more of a chronic issue. So this is usually more of a chronic problem. And these patients are usually older, and they come in with a classic triad. They come in with gait instability, they have urinary incontinence, and dementia from this chronic pushing on the brain. And the way they abbreviate it, or the mnemonic for it is, they're wobbly, can't walk, right? They're wet, incontinent, and they're wacky, dementia. Wobbly, wet, and wacky, or wet, wobbly, and wacky, whichever way you like to say it. So that's a classic way to remember normal pressure hydrocephalus. And again, if I measure the pressure, most of the time it's normal. But from time to time it does go up. And that's what causes damage to the brain chronically, and you tend to get these classic features. All right, now, whenever we have elevated intracranial pressure, that can damage tissues. You get interstitial edema. And it's also going to flatten the gyri, like you're seeing here. These gyri are very flat. Look at this poor guy. It's flat, flat, flat. And it's going to kind of squish the sulci in between, like this sulci. It's all squished up together. There's not much of a space there. And then in adults, you're going to get herniation because the skull bones are fixed. They can't move. So eventually pressure goes up, you wind up herniation. We're going to talk about this in a minute. And then finally, if you're a kid and your sutures are not fused yet, they're still open, well, the pressure will cause your skull to enlarge. So it'll actually enlarge. And these kids look like aliens. Remember those butthead aliens? They literally look like aliens. And that happens anytime there's increased intracranial pressure in a very young kid before the junction of the bones, before the sutures fuse. You get big enlargement of the head. And that's very deformed. I mean, the parents freak out. Everyone freaks out. The kid looks terrible. So very important to pick this up. When the kid has headache and papilledema, hopefully his heart won't get too enlarged because they do get very deformed after a while. Now, treatment. How do I relieve the pressure? Well, usually we place a shunt. So we'll basically shunt this fluid usually to the peritoneum. So we'll just make a shunt through your skin all the way down to the peritoneum and let it drain, let it drain, drain. All right, now a complication of high pressure is cerebral herniation. And this is an important one because now we can integrate pathology and anatomy. Whenever there's an integration, the board like salivates. So let's just remind ourselves, normally we have two membranes here. We have a membrane right here. This is called the falx cerebri. And then we have a membrane here separating the cerebellum from the cerebrum. This is called the tentorium cerebelli. So these are two important membranes that can be involved with herniations. Now, there's three big herniations. The most testable is going to be this one, and I'll show you why in a minute. But let's do them all. The first one is a subfalcine. Remember, this is called the falx. Subfalcine herniation. This occurs when there's some sort of mass or bleed or tumor, something in this area that pushes the brain in this general direction. When it pushes it this way, this gyrus here is called the cingulate gyrus. This is what can ask you anatomy. The cingulate gyrus, which was over here normally, here's one on this side, one on this side, is now being pushed and forced to go under the falx cerebri. That's what we call it a subfalcine herniation. Another name for it is a cingulate gyrus herniation. So know both names because they'll use whichever name you don't know. Cingulate gyrus is going underneath the falx cerebri. Now, here's your anatomy integration. What arteries are right here? Well, in this space right below the falx is where the anterior cerebral arteries should go. That's where they should be. So if I push on them, I'm going to get an infarction in the anterior cerebral distribution. So here's the anterior cerebral artery distribution. Again, we have a right and a left one. So the one on the right is going to be for this side, and the one on the left is going to be for this side. So we have a right and left one that are there. So when it goes this way, it's going to push on the right one first, this side. Now, when it does that, you're going to infarct over here, on this side. That's where you'll get your infarction. So what kind of symptoms did they going to get? Well, do you remember the homunculus? Remember the homunculus? The legs, the lower extremities were over here. Yeah, and then the upper extremities and face were over here. Remember the homunculus? So this is going to cause lower extremity for the opposite side. So this is the right side, it'll be on the left side. Lower extremity weakness, so motor and sensory loss. Motor and sensory loss for the opposite side of the lesion. Okay, this is neuroanatomy. Going back to Mike. Mike's great description of your neuroanatomy. Hopefully you still remember all that for step one. You're gonna need it big time. So lower extremity, motor, and sensory. You can also get some incontinence here as well. Incontinence can occur as well. All right, now just for fun, what arteries here? What arteries right here and here? Well, that's gonna be our MCA, middle cerebral artery. So just for fun, this is the most common site for atherosclerosis and thrombosis. So you get atherosclerotic plaque there, that's called cerebral vascular disease. Then it ruptures, you'll get a thrombosis here, and you'll get an infarction. So the most common site of infarction, again, this doesn't have anything to do with a herniation, but I'm just saying, just for fun, this is the most common site for an infarction. And if you infarct here, you'll get an infarction in this distribution. So this is the middle cerebral. Again, if it's on the other side, it'll look like this. Now, what is this area in between, by the way? This is called the watershed area. That's the area you want to pick if there's hypotension. So if they get severe hypotension, maybe they have a cardiac arrest or a severe gunshot where they lose a lot of blood, this is the area that will be involved from low perfusion pressure. It's kind of in between the two arteries. That's the watershed. Okay, so I'm trying to do as many integrations on this picture as I can. So this is the watershed from hypotension, and this is going to be our MCA, which is the most common site for an atherosclerotic thrombosis stroke. Now, do you remember what symptoms you'll get? Well, for middle cerebral, if you have a stroke here, this is going to knock off the upper extremity and the face. Again, sensory motor for the opposite side. Now, always remember, I can't feel my face when I'm with you. MCA stroke, MCA stroke. That's what he was singing about. He can't feel the face. That's an MC. That's the most common middle cerebral artery stroke. Now remember, if it's on the language side, you can also get Broca's aphasia and Wernicke's aphasia. Broca is where you have broken words, right? You can't really get anything out. So you are, I don't understand what's coming out of your mouth. You have broken words. You know, you're not speaking properly. Now, I understand what you're saying. Your words, hard to hear what you're saying. So their comprehension is good. They just can't express. They can't get the words out. So remember, Broca's, Boca, broken words. Now, Wernicke, K, what? I don't understand what you're saying. You got a word salad. Now, you're speaking beautifully. Your speech is fine. I just don't understand what you're saying. You have a word salad. So remember, Wernicke, what, word salad. It's like splinter, rainbow, forest, you're speaking nicely. It's like a poetry, but I don't understand what the heck you're saying. It's a comprehension. So it's a Wernicke, what? K in Spanish, K, what? Broca, that's broken speech. So you're saying the right things. You're just like, went, store, bought. So yeah, you're making sense, but you're just not speaking very good. You got broken words. So that's a consequence of an MCA stroke on the language side. All right, so very testable MCA strokes. Now back to herniation. We got 3 herniations. The first one was called a subfalsive or cingulate gyrus herniation, and that can mess up the anterior cerebral arteries. Now, let's talk about the most tested. The most tested is a transtentorial or uncle herniation. No, not your uncle. It's a different uncle. It's the uncus of the temporal lobe. So remember, this is the temporal lobe. Over here in the medial aspect, that is going to be your uncus. Now, if there's some sort of lesion up in the top of the brain and it pushes kind of down, so something like over here in this area, maybe an MCA stroke, and the pressure goes up and it pushes in this direction, this uncus, which is normally here, is now going to get pushed down across the tentorium cerebelli. So that's what they call it, a transtentorial herniation, because the uncus is going past the tentorium. It's going down into the space here. Now, what's in this space? There's an artery here. What artery is it? Oh, well, this is the posterior cerebral artery. So anterior is here, middle is here, posterior comes out over here, goes to the back, goes to the occipital cortex. So if I push on this, I'm going to get an infarct now in the occipital cortex. So I'm going to have visual field defects. So what is it going to look like? Well, it's going to be a homonymous hemianopsia. So you're going to lose vision on the opposite side, usually with macular sparing. So I'm putting some macular sparing. So the opposite side of the world is now lost. You can't see it. So again, this herniation's on this side, they're losing vision for the opposite side. So if you stand on the opposite side, they can't see you. They can't see you because you've lost the opposite side of the visual field. So that's pretty cool. That's a pretty cool finding. So again, this transtentorial is sexy because they're going to lose vision for half the world. So if it's on this side, I'm going to lose vision for the other side of the world. Okay. Now, in addition, there's a cranial nerve coming out here. The cranial nerve, it's the third cranial nerve that comes out here. So now you're going to get third cranial nerve palsies. And that leads to lots of cool things. Number one, you're going to get ptosis because the levator muscle for the eyelid, you're going to get ptosis. Now you're going to get a drooping eye, same side, ipsilateral. So ptosis. Now what else are you going to get on the same side? Well, a blown pupil, a dilated blown pupil. Now tell me why. Well, because third cranial nerve has parasympathetics. So if I crush it, you lose parasympathetics. Now the sympathetics are still intact. So now you have unopposed sympathetics. Unopposed fight or flight, fight or flight, fight or flight. You're going to have a dilated blown pupil on the same side as the lesion. So it's on this side, you'll have a droopy eyelid and a blown pupil. And of course the muscles. The muscles are paralyzed. Now there are still letter two that are working. So oculomotor, third cranial nerve does most of the muscle of the eye except for two. Number one, the lateral rectus is still working, so that eye will now be taken out because lateral rectus brings it laterally. And then the superior oblique will bring it down. So that eye is going to be down and out. It's stuck. The other eye is still fine. The other eye is fine, but this eye is down and out. So what are you going to get? You're going to get double vision. Because anywhere I look, except if I look down that way, then I'll have normal vision. But if I look any other direction, this eye is moving, this eye isn't, it's fixed to the down and out position, you're going to get double vision and a headache really bad. So double vision and headache is very common. Diplopia is the medical term for double vision because these eyes are down and out. Again, remember, superior oblique and then the lateral rectus are still working. That's why it's stuck in the down and out position. Now, if you miss this one, I'm going to spank you because imagine you have a chance at a threesome. You have a chance, ladies, you can have McDreamy and McSteamy. You don't have to choose. You can have the wolf and the vampire. You can have both of them. Wow. And then your girlfriend blows it. She blows your chance. She blows it. You can have the wolf and it. She blows it. You'll be down and out. Oh, I can have McDreamy and McSteamy. You'll be down and out. Down and out. So third cranial nerve threesomes, you'll be down and out. Now, gentlemen, do I need to explain for you? You have a chance for a threesome, you'll be down and out. I always have to explain for women. All right, so this is a very testable one because of all these associations. Now, why is it not such a good thing? Well, I can live with loss of vision. I can live with a dilated blown pupil, a ptosis, down and out. I can live with that. But I can't live as this pushes on the brain stem. It's going to push on midbrain and the pons, and you're going to get what's called these linear Duret hemorrhages. Bleeding in the brainstem can kill you. So I want to put this term, Duret hemorrhages. Yeah, Duret hemorrhages. These are basically, because of the pressure, you're stretching, you're pushing and stretching on the midbrain and the pons, and you're causing the little vessels to tear. You're tearing the vessels. So you get these linear hemorrhages. We call them Duret hemorrhages. And again, our brainstem is critical. You're bleeding your brainstem, and that can kill you. So not good. I don't want any herniation. This is definitely not what I want. All right, now the most deadly of all herniations is going to be the tonsillar, cerebellar tonsillar herniation, because it's rapidly fatal. The reason for it is if there's something up here, anywhere in the cerebral hemisphere, and it pushes the brain downward, these tonsils in the mid area here of the cerebellum, these are going to get pushed down into the foramen magnum. Now remember, this is a bony structure. This is the foramen magnum right there. Accurate, right? See the bone? That bone won't move. So let me just erase this first one. Good. Yeah, this is the foramen magnum here. So when you push it down the foramen magnum, it's literally crushing the medulla oblongata. So what's in the medulla oblongata is your respiratory centers. So this is going to lead to sudden cessation of breathing. You're just going to stop breathing because the medulla oblongata. Your respiratory centers. So you just stop breathing. So that's, if you're going to have a herniation, that's definitely, you don't want any herniation, but that's certainly what you don't want. When those tonsils rapidly go down, push it on the brainstem, medulla oblongata gets compressed, that's the end of your life. Very, very sad. And that does happen quite a bit when you have rapidly expanding hematomas, rapidly expanding tumors that bleed into themselves. And everything's swell rapidly in the brain. This is a common herniation that will kill. Not a good thing. All right, feel good about this anatomy integration? Very, very cool. All right, perfect time to take a break. We'll come back. We'll do CNS infections. And now we get to do microintegration. I'll see you.